Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. We are available on YouTube and you can access all lecture related information on YouTube. Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. We have a YouTube channel where all the videos and the lectures are uploaded. You can access them as and when you want. We also have a Telegram group which you can join. It will help you in accessing all lecture related information. We have a Google Drive where the PDF of all lectures are uploaded and a master integration key which coordinates between the PDF as well as the YouTube lectures. These are the disclaimers. And we are with phase 3, the recorded pathology lecture. And today we are with Pursue 7ZC1, which is neuropathology. And the topic of the day is very interesting, squash cytology in CNS lesions. And to talk on that, we have Dr. Shristi Butta, who is an MBBS honors gold medalist, MD pathology, demonstrator in the Oncopathology unit of the Department of Pathology at IPGMER and SSKM hospital. She's got multiple publications in national and international journals, with special interest in neuropathology, molecular genetics, and haematopathology. With this, I would request Dr. Shristi Butta, ma'am, please start your lecture on squash cytology and its uses in CNS lesions. Over to you, ma'am. Thank you so much.
So a very good evening. So today's topic is squash cytology in CNS tumors. So let's start. So what do we plan to discuss today? We plan to discuss about the squash cytology, the history and overview, different types of astrocytomas, the cytological manifestation, especially the grade 2, grade 3 and grade 4. We will also be discussing about pilocytic astrocytoma, glioblastomas, ependymomas, meningiomas, medulloblastomas, and subsequently will be ending with the artifacts noted in squash cytology smears. So let's start. So the origin of squash cytology dates way back to the year 1930. Okay, and it was in the year 1930 that squash cytology was first done for a CNS tumor. It is important to note that the soft consistency of the CNS tissue is best suited for squash cytology, which is in fact a hindrance for frozen sections. Moreover, the ice crystal artifacts that are seen in frozen section makes the interpretation of frozen sections difficult. Further, squash cytology is a simple, rapid and inexpensive and fairly accurate technique, okay, for providing an intraoperative diagnosis. With the advent of stereotactic brain biopsies, it is important to note that the role of squash cytology has increased. Okay. Further, pathologists should train themselves in the cytomorphological interpretation of such scanty stereotactic brain biopsy tissues. The intraoperative diagnosis with squash cytology, okay, can be done as early as about 10 minutes. Okay, with the rapid H&E and Leishman staining taking less than 10 minutes for staining and just a few minutes for evaluation, okay, squash cytology can provide a rapid intraoperative diagnosis. So what is the need for this squash cytology? The need is to ascertain the nature of the lesion, okay, and to ascertain the margin status. So that is very, very important. Okay, besides ascertaining the nature of the lesion, whether it is benign or malignant, and important in ascertaining the margin of the tumor. It can achieve targeting the lesion and provide guidance to the neurosurgeon in modifying and monitoring the surgical approach. Okay, it can also help in assessing the margins as we have discussed in a biopsy specimen. Further, it helps in ascertaining the adequacy of the stereotactic biopsies as well as in collecting the samples for investigations such as a culture when you have a granulomatous lesion or an inflammatory or infective disorder. Now, frozen sections and squash or imprint cytology are complementary to each other, and when both are available, okay, then it must be noted that frozen section takes the upper hand to provide a final intraoperative diagnosis. Distinct advantage of frozen section is the architecture that it provides. Okay, so it gives a more cytomorphological architectural diagnosis and hence helps in finer histopathological typing. So there are certain advantages of squash cytology over the frozen section, and therefore squash cytology is better than frozen section for CNS tumors per se. Okay, why? Because it is technically more simple, it has an ease of preparation. Okay, it does not use a cryostat, it is quite less expensive, and even a small sample can provide a high yield. But however, we have certain limitations of squash cytology as well. Soft tissues like that of the CNS are easy to smear. However, tough tissues which are fibrotic, or some of the tissues within the CNS, or some of the tumors within the CNS like a fibroblastic meningioma, etc., are difficult to smear. So architecture as well cannot be ascertained with the help of a squash smear. Now coming to the macroscopic abnormality identifiable at surgery itself, you can see some degree of necrosis in the surgery itself in glioblastoma and metastatic tumors. Even lymphoma, anaplastic oligodendroglioma, medulloblastomas can show a necrotic morphology typically, and it has to be noted that hemorrhage is more commonly noted in glioblastoma, metastatic tumors, hemangioblastoma, anaplastic oligodendrogliomas. Okay, extracerebral tumors. Okay, typically it has to be noted that calcification is very common and noted in meningiomas, craniopharyngiomas. Intracerebral tumors like oligodendroglioma and pilocytic astrocytoma can also show some degree of calcification. Moving on to the normal brain, as you can see that this is a normal brain. Okay, you can make out the astrocytes, which are typically very small. Okay, they have a somewhat a star like shape. Okay, there are a few oligodendrocytes that are very small. Okay, that you can make out. Okay, in addition you can also make out the star like astrocytes. Okay, and what is this? This is a vessel that you can make out. Okay, lined by flattened endothelial cells. So this is a normal brain histology. How is it different from a tumor? Let's discuss. Now this is somewhat a reactive change that has been seen. This is a reactive gliosis. You can see that the astrocytes typically have very nice and thick star-like cytoplasmic processes that you can make out here. Okay, this is a reactive gliosis, okay, with a gliotic background. Okay, these are the astrocytes that you can make out with finely dispersed nuclear chromatin and inconspicuous nucleoli, right? Okay, what about this one? What do you see here? You can see a foreign cluster of tumor cells. Okay, it's a foreign cluster. Why do I say it's a foreign cluster? It doesn't seem like brain. Okay, if it doesn't seem like brain, with the background showing you a reactive gliotic change, it is somewhat a metastatic change. Okay, so a metastatic carcinoma. Moving on to pilocytic astrocytoma. Now this is a WHO grade 1 tumor. It has typically a low cellular yield. Bipolar cells with cytoplasmic processes are commonly noted. Rosenthal fibers may be seen. However, there is no necrosis or mitosis. And the most common DD of it is a reactive gliosis. So what do you see here? You see that you have this tumor cells here. Okay, and look at the nucleus. The nucleus has turned a little bit hyperchromatic. Okay, the nuclear details are different from that of a reactive gliosis, as you can make out. Can you make out? Okay, so these cells typically have a hyperchromatic nucleus with inconspicuous nucleoli. The cytoplasmic processes can be easily made out. The background looks gliotic. Yes, right. And so this is again a picture of a pilocytic astrocytoma with bipolar pyloid cells with fine cytoplasmic processes that you can make out. This eosinophilic material that you can see here is nothing but a Rosenthal fiber as seen in a squash cytology smear. What about this one? This is a multinucleated cell, okay, with peripherally placed nuclei, and is very characteristic of a pilocytic astrocytoma. This is referred to as a pennies on a plate appearance. Now coming to astrocytoma CNS WHO grade 2, in case of a grade 2 astrocytoma, unlike a grade 1 astrocytoma, this is moderately cellular. Cell clusters are more commonly seen around a thin-walled blood vessels. Okay, cells are often round to oval and elongated, giving it an astrocytic look. Okay, cytoplasm is somewhat scanty and background looks fibrillary. Okay, and the DD is a reactive glioma. Yes, so what do you see here? You see somewhat an astrocytic neoplasm with a background which is more fibrillary with elongated cytoplasmic processes. Cellularity is more as compared to a pilocytic astrocytoma. Okay, and the nuclear details, as you can make out, the nuclei are a little bit more hyperchromatic, okay, as compared to a pilocytic astrocytoma. And even the age will give you a clue that this could be a case of a diffuse astrocytoma, previously called, okay, and now referred to as astrocytoma WHO grade 2. So you can leave the report as a low grade astrocytoma in this case. What about CNS WHO grade 3 astrocytoma? The smears are moderately to markedly cellular. Okay, there is some degree of nuclear pleomorphism as well. Mitosis is more commonly seen and background appears fibrillary. However, there is no necrosis and there is no microvascular proliferation. So what do you see here? Yes, the cells are pleomorphic. Pleomorphism is just catching your eye here. Okay, background looks fibrillary, and the cells are yes, they have a high N by C ratio. Yes, they look very pleomorphic. Some degree of mitosis can also be seen here. Okay, so you can make out the mitosis, right? So when you have a fibrillary sort of a neoplastic lesion whose background is more fibrillary with cytoplasmic processes like these, okay, and the neoplastic cells are showing some degree of pleomorphism with some degree of mitosis as well, then that gives you an impression that you're dealing with a case of a astrocytoma WHO grade 3, previously called as anaplastic astrocytoma. How about glioblastoma? Now that is called as a CNS WHO grade 4 tumor. Here too the tumor has a markedly cellular look. It has a high degree of nuclear pleomorphism and mitosis. In addition, necrosis and microvascular proliferation may also be seen. So what do you see here? You see the microvascular proliferation that is typically noted in a case of a glioblastoma. And what do you see here? You see the glomeruloid tuft of endothelial cells that are typically seen in case of a glioblastoma. The smear is very cellular, as you can make out, and the background is fibrillary, right? So the fibrillary look and the glial look of it gives you an indication that it's a yes, it's a glial tumor, okay, and the hyperchromatic nucleus, brisk mitotic activity, variable degree of necrosis in the background, glomeruloid body formation can give you an indication that it's a case of a CNS WHO grade 4 tumor. Further, you can also make out the vascular endothelial cell proliferation, okay, as it has been seen here, okay. What about a pleomorphic xanthoastrocytoma? It's a CNS WHO grade 2 tumor. It is a superficially located tumor. There is some degree of cyst formation as well. Cells look very pleomorphic, as the name implies. Okay, however, it behaves like a grade 2 tumor. Okay, and there is some degree of vacuolation in the cytoplasm as well. So the vacuolization of the cytoplasm will give you an indication. Further, mitosis and necrosis are absent. So as you can make out here, the cells are looking very pleomorphic. Okay, yes, the background is glial, so that is giving you an indication that it's a case of an astrocytic neoplasm. Okay, the cells look pleomorphic. There is some degree of foamy or vacuolated cytoplasm that you can make out here. Okay, so that is giving you an indication that this is a case of a pleomorphic xanthoastrocytoma. Moving on, what do you see here? You see, yes, you can make out that these cells have a pink cytoplasm, right? Further, you can also see here. Okay, so this is the gemistocytic variant of an astrocytoma. The gemistocytes have a peripherally displaced nucleus, okay, and a glassy pink sort of a cytoplasm here. So an eccentric nucleus with a pink cytoplasm gives you an indication that these are gemistocytes. So now moving on to oligodendroglioma. Oligodendroglioma is a tumor composed of round cells. Yeah, so these are the oligodendrocytes, which have turned tumors, right, or neoplastic. Now these cells typically have a speckled chromatin, and oligodendroglioma is typically associated with calcification and a fine capillary network. However, it must be noted that a perinuclear halo is typically absent in squash smears, and mitosis is very rare in a WHO grade 2 oligodendroglioma. So what you can see here, you can see the fine capillary network that is typically associated with a oligodendroglioma. Associated with these round cells, okay, which lack the perinuclear halos. Okay, the perinuclear halos are lacking. So what you can make out here, as besides these round cells, you can also see these cells. Okay, what is this? What is this? These cells have an eccentric nucleus and a dense pink cytoplasm, right? These are the gemistocytes or the mini gemistocytes. These mini gemistocytes are very characteristic of an oligodendroglioma. Okay, so besides that, you have a fine capillary network, you have some degree of calcification, okay, round nucleus, lacking a perinuclear halo, some degree of gemistocytic change. Now, a WHO grade 3 oligodendroglioma, however, has pleomorphic nuclei, variable degree of mitosis, and an eosinophilic cytoplasm. If we see here, we see that these cells are round. Okay, there is a change of mini gemistocytes, very cellular smear. Some degree of mitosis can also be appreciated. Okay, as you can make out, this was previously called as anaplastic oligodendroglioma, now called as oligodendroglioma CNS WHO grade 3. If you look at the higher power, you can see that the cytoplasm has become more eosinophilic. That means it's gone into more gemistocytic. Okay, so yes, and there is some degree of pleomorphism as well, and the background looks fibrillary. So yes, it's a grade 3 oligodendroglioma. Moving on to CNS WHO grade 2 ependymoma, that also has a fibrillary background indicating that it's a glial tumor. Okay, it has round to ovoid cells with speckled or stippled chromatin. Papillae may be seen. Rosettes are very characteristic of an ependymoma. Okay, it may be true rosettes or it may be perivascular pseudorosettes, and calcification, very, very important. Now coming to this, what you see here, you can easily make out that you have a papillae. Okay, and these papillae are lined by these round to ovoid cells. Okay, here. And what are these? These are the rosettes that you can make out. Okay. So a very, very characteristic picture of an ependymoma. Here again, you can make out these rosettes, these little ones here, okay, and the cells are round to ovoid with a speckled or stippled chromatin. The rosettes have been highlighted here as well. Okay, so you can easily make out these rosettes, very characteristic of an ependymoma. Now coming to myxopapillary ependymoma, this was previously called as CNS WHO grade 1 tumor, but now called as a CNS WHO grade 2 tumor. right? They also have a papillae, but the stroma is variably myxoid. The cells appear to be round to ovoid. Quite similar looking is a chordoma and a metastatic deposit of an adenocarcinoma. So they do come under the differentials. Coming to the myxopapillary ependymoma, yes, you can make out the rosettes. And what do you see further? What are these? This is the myxoid stroma that you can make out here. So they have a papillae, okay, and these papillae are lined by these round to ovoid cells, okay. And what are these? These are the fibrillary processes, giving you an indication that this is a glial tumor. Now moving on to another important tumor, which is a meningioma. Now squash smears, usually in case of a meningioma, show a characteristic whorl appearance, okay, and they show syncytial arrangement of meningothelial cells. There may be some degree of concentric calcification or samoma bodies that may be seen in case of a meningioma. The differential diagnosis in a squash smear of a meningioma closely resembles a schwannoma, especially the fibroblastic or the fibrous meningioma, which has a spindle cell nature. So what do you see here? You see the characteristic whorl, okay, and a syncytial arrangement of these tumor cells. There may be some degree of pleomorphism, but however, it is usually not seen. This is a case of a fibroblastic meningioma. And what are these? These are the samoma bodies or the calcific bodies that you see in case of a meningioma. And what are these? These are again the whorls that have been highlighted here. Okay, so these are the whorls. So medulloblastoma. Now medulloblastoma in a squash smear usually shows undifferentiated small round blue cells. Yes, so it's a small round blue cell tumor, and these small round blue cells may either be present in clusters or isolated. Okay, each of these cells have a hyperchromatic nuclei with indistinct cytoplasm. Some degree of homerite rosettes may also be seen in well-differentiated cases, and rarely you can also make out cytoplasmic vacuoles. So we see here that this is a case of a medulloblastoma, and we compare it with the normal granular layer of the cerebellum. Okay, what do we see here? We see quite a cellular smear, okay, with undifferentiated round to ovoid cells with hyperchromatic nuclei to inconspicuous nucleoli, right? And these cells show variable degree of mitosis, okay, variable degree of mitosis evident, and some degree of rosetting as well. Okay, we can see the rosettes in the next slide as well. So we see here, okay, this is a smear of a medulloblastoma. It has a characteristic carrot-shaped nuclei, okay, and some degree of rosettes and a high mitotic activity. What about the artifacts noted in the squash smear? The artifacts, now artifacts like loss of cytological details may be seen, okay, if you apply extra pressure to the slides while pulling. That is the shearing artifact that may be seen. In addition, there may be some degree of a drying artifact, and when the tissue is quite tough, like a fibroblastic meningioma or a schwannoma for that matter, they are difficult to spread. So the tough tissues usually show this sort of an artifact, right? So eventually summarizing, intraoperative squash smear cytology is quite a useful technique, especially for CNS lesions, okay, which are quite soft in consistency and easy to smear. In a resource-poor country where frozen section is not available everywhere, squash cytology can be a mainstay in providing a rapid intraoperative diagnosis to the surgeons regarding the extent of the excision. Squash smear cytology is a simple, rapid, and cost-effective intraoperative technique, okay, and is totally dependent on the expertise of the pathologist. So a pathologist should train himself or herself to see a squash smear and report it accurately. A high diagnostic accuracy can only be achieved with squash cytology by taking a clinical as well as a radiological finding into consideration. So thank you so much for your patient hearing.